Welcome to this webinar brought to you by SBK Healthcare and sponsored by CUP Foundation, Joe's Friends. To find out more about further educational podcasts, webinars and forums, please do visit our website at www.sbk-healthcare.co.uk. In this webinar, you'll be hearing from Dr Harpreet Wasan and Dr Anthony Greco, who will be in discussion tackling the question, cancer of the unknown primary, is the unknown now known? It is my pleasure to hand you over to the webinar sponsor, John Simmons, Director, CUP Foundation, Joe's Friends. John, over to you.
Thank you, Sarah from Birmingham. And on behalf of CUP Foundation, Joe's Friends, may I welcome you all to this very special event. I recognize a few old friends from the delegate list, but the majority of people, I think, are new to some of our events. And so a particularly warm welcome, and I hope you'll find today very interesting and very helpful. And it reflects the fact that there are so many new people, reflects the rapid changeover, I think, in CUP MDTs in this country. Today, we have the very special opportunity to engage with the world-leading CUP authority, Dr. Tony Greco. I don't know of anyone else in the world who has been active for so long in this field as a researcher and, of course, a practitioner, providing empirical evidence that has informed practice. They may not know his name, but patients around the world have benefited from his work, and patients in the future will also benefit from his expertise and his work. I'm going to hand over to Dr. Harpreet Wasan in a moment to start the conversation with Dr. Greco. Before doing so, I would like to thank them both for the invaluable support they have given to this charity over the last 15 years. Both are highly valued members of our advisory board and have guided me over the years, sharing their knowledge patiently with a non-clinician and supporting our work most generously despite their busy timetables. Let me now hand over to Harpreet to engage in discussion with Tony. Harpreet has also been in the CUP field for decades. He led the first major UK CUP study, CUP1, and is the PI for the active CUP PEM trial. Harpreet.
Thank you, John, and thank you to the organisers. I wanted to reflect on your involvement in continuing to really excite us in this field where we wanted to take forward, and thank you for everything that you've done. For those who haven't visited John's website, which started probably about 15 years ago, they should, because it's a minefield of information, and really single-handedly John has developed this. So thank you for that. I'd like to just welcome Tony. As John said, he's a world authority on CUP, but many of you may not know. He's also responsible for patient access to research through phase 1, and essentially was one of the founders of the drive to develop the Sarah Cannon network. So his achievements have been absolutely amazing for our patients to try and match treatments to patients within or without CUP, and then developed into the CUP area. And so it's a privilege and a pleasure really to talk with Tony again and get his insights, which is so educative for all of us, just based on his experience, but also his ongoing work. So welcome, Tony.
Well, thank you very much, Harpreet. It's great to be here. I'm happy to be discussing this issue with you today.
So Tony, I'd like to start off by perhaps going back historically to the development of your involvement in CUP, and since your pivotal publications in the late 90s and 2000s about establishing chemotherapy as a standard of care. Can you give us some insights as to how that developed and how you thought that would develop in terms of improving patient outcomes before you know, the advent of sort of newer technologies of both treatment and diagnostics?
Yes, if we go back several decades, you know, this was a very unusual, bizarre form of cancer where patients presented with metastasis, and yet one could not find the anatomical primary site. And understanding this was important to me. And the understanding in part, at least a partial understanding, came from autopsy studies, where we did many ourselves. I participated in at least 40 over the last 40 years. And, but more importantly, there have been over 800 patients published. And it's very important to recognize that CUP patients, the majority of them, you can find a small primary at autopsy. So they have a primary. That's important. That implies, and we subsequently know it's true, that there are many cancer types that make up CUP. It's not a single cancer. That's been one of the problems over the years, that it's difficult for people to change their opinion about this. It is a biologic entity. It's a syndrome. And every cancer type, practically, I've not run into one yet that hasn't been able to do this, can produce this syndrome. And we don't know why the primary remains so small. And yet there are metastases, which we find, and we can biopsy those. So back in those years, we didn't have much in the way of useful treatment for many cancers at all that were advanced. So we were stuck with, even if you knew what the primary was before the patient went to autopsy, the treatments weren't very good. There were a few patients that could be treated, like you could treat breast, and some of the patients with lung responded, and some neuroendocrine, certainly germ cells and others. So we began to develop empiric treatment with broad spectrum anti-neoplastic drugs in hopes that some of the patients would respond to treatment. And we really couldn't determine the tissue of origin at all in the past in these patients. We did, however, begin to develop knowledge about certain subsets, but it was all based on clinical features and relatively crude H&E histology, pathology. There were virtually no immunohistochemical stains. And we were able to define certain subsets back then. For instance, women who presented with axillary masses or adenopathy that was adenocarcinoma, those patients subsequently were recognized, most of them have an occult breast cancer. It's so small, you can't see it in the breast. Mammograms don't show it. You can't feel it. Back in those years, many of these women had a mastectomy, and 60% of those women, if you did multiple sections through the breast, you found a tiny primary, sort of a autopsy before a patient dies, if you will. And if you treated those patients as if they had breast cancer, they did as well as patients with stage 2 breast cancer who had a known primary in the breast. That's well recognized now. That's so that's important, because that's a prototype of what a known primary is, a small primary that spreads. Another one, and I'm only going to talk about one more, but there are other favorable subsets, is head and neck squamous cancer that presents in the neck. Yet after careful examination, you cannot find the primary, which almost always is in the oropharynx, base of the tongue, pharyngeal region. And if you treat the patient as if they have that, they do as well as those patients who have a known primary in the head and neck region was spread to the neck. So these are important features of the past, and things have changed. You know, the present occurs over a time period. You can't mark a particular time when the past becomes the present in terms of medical knowledge and therapies.
Thank you, Tony. And that sort of explains why you've also been a leader with your colleague Ainsworth in the field of germ cell tumors, because you had to encompass overlaps between the two, and the outcomes for those, of course, are where we would like to get CUP to eventually. So that's really interesting. Can I ask you, in those days, before we move on to the sort of molecularly guided sort of diagnostics and current technologies, do you think there was a single most important radiological development that helped with this, or you think that it still remained enigmatic despite all those clinical developments?
Well, yeah, there were a couple important diagnostic tests that opened the field up a lot. CT scanning was obvious. I mean, because before that, we couldn't even detect, for instance, a 2-centimeter pancreatic mass. There was no way to see it. So CT scan, we found a lot of the primaries, not just in the pancreas, but other places. So that excluded a lot of patients that really didn't have CUP. And this still is ongoing today. If you find a primary, no matter how small, the patient does not have cup. If you don't find the primary, it's likely just too small to find clinically, and you can find them at autopsy. I didn't mention that those patients where the primary is not found at autopsy, the pathologist cannot see it or feel it. That doesn't mean it's not buried in one of the organs, and it would take thousands of sections through virtually every organ to find it. Not practical, not done. So basically, I think virtually every patient with cup has a small primary. And does the size of the primary matter once it metastasizes? I don't think so. I don't think so. It's important to know what type of cancer they have today, much more important than it was 30 years ago when we didn't have very good therapy.
And I think that amplifies the fact that even today, a high quality CT is still the critical first step in deciding where we think the primary is, and probably gives us clues in probably 85, 90% of patients when we're hunting for source of cancer. So that's really an important message that continues. So that's our first test of choice,
Yes.
in addition to potentially other radiological choices.
Yes.
So can I move you on now to the sort of the pathology side and the diagnostic evolution from the pathologists, and obviously integrating that into more of a team effort, looking at different discussions across a multidisciplinary team. So from the pathology and then moving on to more modern methods of pathology, how did that develop to help you
Yes.
with your program?
Yes, it's a good question. Pathology has evolved too, still evolving, particularly with immunohistochemical staining, which is critical in many diagnostic workup in a lot of patients with known primary cancer, as well as those with unknown primary cancer. It's developed slowly. Initially, we didn't have any stains that we could count on. And these stains are basically, we're detecting proteins, of course, come from RNA and from the basic nucleic acid function in the cells. And they're relatively specific for certain cells. So if you find proteins that are relatively specific for breast cancer in a cancer cell, you can make the inference that it's likely a breast cancer, and you're usually going to be right. So there are hundreds of these stains have been developed. And over the years, there are panels of stains that pathologists use. And when these stains are used with the typical histology, the way the cancer looks, and the clinical features of the patient, which is critical, where the metastases are, obviously the gender, the past history of the patient, and you put these together, we now have an ability to determine the tissue of origin by immunohistochemical staining, at least in our experience, in about a third of CUP patients. And that's very important because then you know the tissue of origin. Even though you have not been able to find the anatomical primary site, you know where it came from, and you're right most of the time. And then you can move on in that patient to evaluate and subsequently give precision therapy for the type of cancer that they have. So that is developed, it's still developing, and it's part of the evaluation of these patients. I could give specific examples if you want. I just don't want to take too much time.
Perhaps we could come back to that if there are any questions around those sort of specific processes. I wanted to ask you another sort of logistical or process question. Do you think that when we have CUP tumor boards or CUP pathology reviews in an MDT, do you think that this is within the expertise of every pathologist, or do you think they should be centralized to specialized pathology?
Well, I don't want to insult any pathologist, of course, but like anything else, their specialists sometimes are focused and narrowed down and perhaps have more knowledge in one area than another. And I think it's critical that pathologists to understand what CUP is and understand which stains to apply for certain clinical presentations becomes very important. And I think that's where you come up with 30 to 40% of a tissue of origin based on immunohistochemical staining and clinical features. And it could be lower than that with the lack of experience. But the oncologist is also important in this picture the physician along with the pathologist. So it's an important to work together in that regard.
I'm going to put you on the spot a little bit in your practice. Can you estimate, and you won't insult anyone, can you estimate when you get referrals in the US over the last 10, 15 years, how many times you think out of maybe 10 or 100 you change the diagnosis based on your specialist input with your team?
Probably 10 years ago, we changed the diagnosis in 60% of the patients. And that was based on the fact that we had not only immunohistochemistry was developing and still is, but also molecular testing. So when the patient came, they didn't have that particular expertise or didn't put it together. But that's changing as we go by, at least in my practice in the United States and in our institute. And it's less now because more and more physicians and oncologists and pathologists are using the techniques we have available. And therefore, I'm agreeing with what they're finding more often now. Probably only 2 out of 10 do we change or do we disagree about what the tissue of origin is. Whereas it was probably 6 to 7 out of 10 years ago, 8 years ago.
That's a really nice insight and suggests that still possibly up to 20% of patients may have a revised diagnosis with extra care and extra detail. So that's still an important message, I think, to get across, that these patients are challenging in many aspects, including their general care. You touched on the newer technologies, and you published a really nice multi-center study of the tissue of origin and expression. Can you just sort of give some insights as to how that sort of has influenced your practice, at least in the US, where you may have access to these tests easier than we do?
Okay. Yeah, it was really in around 2008 that this technology became available, and we began to look at it and study it in these patients to try to determine if we could find the tissue of origin, not the anatomical primary site, but based on the study of the metastasis with molecular testing, so-called molecular cancer classifier assays. That's a particular molecular test, and there have been several developed, but one is sort of in the United States, the only one that's we use now. And we know that can be very accurate and help us in the 2/3 of the patients where immunohistochemistry cannot give us a tissue of origin. So when we apply the clinical features, immunohistochemistry, and over the years now we have accumulated a lot of information, published a lot of data using the molecular cancer classifier. It's an RT-PCR test, and now can determine the tissue of origin fairly accurately. No test is perfect, in upwards of 90 to 95% of patients with CUP. So we know where the cancer is coming from. And we've validated this in many different ways. And we can now treat the patients more specifically and do additional genetic testing, next generation sequencing, either on their tissue or their blood, to interpret that in the context of what type of cancer they have, just like we do when we know a patient has a known cancer. It's like, if you know a patient has an intrahepatic cholangiocarcinoma, you can interpret next generation sequencing because they may have important treatable genetic alterations. The molecular cancer classifier cannot determine genetic alterations. That's up to more comprehensive next generation sequencing. There are different types of molecular tests.
So in an ideal world, apart from the MDT and the traditional methods of radiology and pathology, you would think in an ideal situation, we should also be doing, to have more information, and it may not change the outcome in all the patients, the tissue of origin testing and also the molecular testing at the level of next generation sequencing. Is that how I've interpreted that?
Yes, in my opinion, it's important to know the tissue of origin to properly interpret the next generation sequencing. And that's not always done because of not universal agreement or understanding about these CUP patients. So yes, that's correct. In an ideal world, you would want to know, you want to determine the tissue of origin and then determine whether there are molecular alterations which could add to your ability to treat these patients in a more precise way for what they actually have.
So then the link for that to the patient outcomes, there's two aspects. Obviously, we know that a lot of our patients are very poorly at presentation, even more so during this COVID era and following it because of later presentations, which has been a problem with CUP, particularly in the UK, where about a third of patients come in actually diagnosed via acute casualty or emergency rooms, as you'll call them, as their first step into the system. So apart from the sort of challenges of that, what I wanted to ask you was, from the diagnostic point of view, and we'll come back to the question about the performance status and how we manage them in a minute. I wanted to ask you whether you were disappointed, surprised, or otherwise when the two trials that tried to match in a randomized fashion the tissue of origin testing to a matched treatment, both Karim Fazazi's trial, the JEFCAP run through Europe, and also the Japanese study. What was your take on that? Because they couldn't clearly show a benefit to the individual.
No, that's right. I think there are a couple of issues here. One, you have to look at the timing of these studies. And the reason this is important is that therapy has evolved rather quickly in terms of advanced cancers of known primary site. For instance, in advanced non-small cell lung cancer in the United States now, there are 10 FDA-approved therapies for targets. That's amazing, 10 that patients can do very well. For instance, immunotherapy is exploding. Other targeted treatment, as you know, in cholangiocarcinoma, intrahepatic, there are at least 2 now in the United States. Targeted drugs are approved. So therapy has rapidly improved. The studies you're talking about were designed a decade or more ago. It took many, many years for the Japanese study to have like 115 patients, and 25 of them were lymphomas. That's a very flawed study. And I'm all for studies, but you have to look critically at the situation. So the therapy has evolved. The best study, the European study, the JEFCAP-4 study, maybe I pronounced it wrong, but that's the Fazazi study. That was designed a dozen years ago. There was virtually no targeted, no treatment, no immunotherapy. Plus the patient population was skewed. What do I mean by that? When oncologists see a patient and they think the patient has a treatable cup, now they don't know for sure, but if they think they have a treatable cup like breast or like ovarian, I can name others, they're much less likely to place that patient on a study for empiric therapy. So what that does is the accrual of the patient is skewed towards the patients that have least treatable cancers. And that's where the problem lies, Harpreet, the skewing of the accrual. If you look at the Fazazi study, a large number had pancreatobiliary cancers. We can even treat them better today than we did when that study was designed. And a large number of them had that. So you wouldn't expect gemcitabine and cisplatin, which is the control arm of empiric therapy, to be any better than the standard site-specific treatment for pancreatic cancer, which is very similar. So it's basically one treatment which is the same versus another one. But if you looked at a subset of patients in the Fazazi study, those that were not expected to respond to gemcitabine and cisplatin, it was only 60 patients. So small number, but that the 2-year survival was over 20% versus less than 10% in the empiric arm. You can't make much of that because it's not statistically valid. So those studies, in my opinion, are flawed studies. If you determine the tissue of origin and you determine that you don't have a very treatable cancer based on the therapies we have today, the patient's not going to do very well. On the other hand, if you determine a form of cancer that's highly treatable, the patient's going to do much better. So we can get to that in the future, in the future discussion today. I think certain studies need to be done to clear this up once and for all.
So I'd like that's really, really excellent in terms of the analysis, because it's always difficult with even standard studies, even non-cup studies, when you see differences in subsets, but not in the whole study, and how we interpret them and license and move on from there. But I wanted your view on more the fact that, given that there is a changing landscape, given that CUP is heterogeneous, do you think that the future studies are actually more like real world evidence umbrella type studies, like some of the things you're doing in the US, like the TAPUR study, etc.? Do you think that's the future of these studies? Because by the time we design and run studies, we may be behind the curve already in a subset of these patients. What's your thoughts?
Yeah, a couple of things, and I agree with you there that we have to. First of all, the previous studies, I didn't mention, it's important, and you did touch on it. You're talking about taking 30 different cancer types and putting them in a randomized study. That's kind of ridiculous when you think about it. CUP is not one cancer type. Even breast is not one cancer type, but at least we have large subsets. CUP, every patient is likely different from the next patient, unless you have hundreds and hundreds of patients in a study, and then you might have certain groups that are similar. The other issue on what to do and how to study this to advance our knowledge, we have to have study designs that are a little different. We can't design a study and then take 12 years and never change the treatment. If the treatment for a particular cancer gets a lot better, like immunotherapy has for many cancers, you have to incorporate that into the study design so the patients on that arm can get the better therapy. It's difficult, and patients and doctors often don't want to be on a control arm where everyone may think that it's an inferior therapy. There are ways around this, and we've talked about it, we've written about it recently. What studies should we do? And if you want, I can briefly tell you what I think needs to be done in quickly, or we can wait a little bit in this discussion and go over that later, whichever you think.
I think it flows nicely for you to just give your insights now. We're running well to time, and then we'll take a couple of points that have come through from the audience after this bit of your discussion. So if you do extrapolate on that, that'd be brilliant. Yeah. Okay.
With the limitations of randomized studies in CUP, I still think it would be good if we could do a good randomized study that's on the front end, where you define the CUP patients. They don't have an anatomical primary site. They aren't in the favorable subsets. And you can randomize them to site-specific treatment based on, you've determined the primary site by molecular testing and immunohistochemistry, or you give them either site-specific treatment, empiric therapy, or the third arm would be targeted therapy. So that would be the randomized study. I'm not sure that can be done unless there's huge numbers with international cooperation, almost like the study that's going on right now. And we'll get to that in a minute, I guess. So that would be reasonable. But I like a practical approach much better. We've been able to define all these fairly treatable cancer types, as well as some that aren't so treatable, by immunohistochemistry and by molecular testing in the CUP population. Some of these are lung, renal, breast, colorectal, urinary, urothelial, GE junction, gastric. We've been able to identify these in relatively large numbers in the CUP population. So why not do phase 2 studies, identify those CUP patients, treat them with site-specific treatment, large phase 2 study, not randomized. Let's just say in lung cancer, where you could have probably 200 patients easily in a phase, and you would do molecular testing, you would treat them all like lung cancer, because that's what most of them are. And then you would compare that to therapy, modern therapy of known metastatic lung cancer, and do that in each of these subsets. I don't need to have a randomized study if I can see the survivals are very similar with that phase 2 approach versus the historical controls of known advanced primary cancer. That's sort of where I am right now. Now, the future could hold a lot of different variables, but that's where we are right now.
I mean, I think that's really interesting that study development in these sort of either molecularly or behaviorally heterogeneous subsets need to be thought of as very different. And that's a really nice idea that hopefully you can get some funding to develop. They're always challenges, but if anyone can do it, you could do it. So that's great. It's a great idea, Tony. Can I just take some audience questions and then or points? So what I'm going to do is I'm going to read out the audience points, and then I'm going to give a comment, and then just for the flow of a Zoom-based meeting, then if you could want to comment on that in any different way, or if not, we can move on to the next point. So I think some of these points have been covered. So we've got an attendee who has basically asked the question, what differentiates pathologically the adeno that is most in keeping with upper GI HPV origin, which is, so I'm adding this now as a statement, which in our experience is one of the commonest frameworks when we see the pathology outputs, and we maybe ended up treating as a cup, and those which are true cup as for trial purposes, different pathologists and our MDT seem to have different perspectives on this. So I think from my point of view, we have this discussion almost weekly where we have a pathology, and even in our preliminary analysis of the CUP1 trial, 2/3 had a GI type of profile. And this is very non-specific, and it's very difficult to differentiate across the GI axis. And you have to make a pragmatic decision, but it's not the pathologist who drives that outcome. It's exactly what Tony, in my view, said earlier. It's a combination of the radiologists and the pathologists giving their input, and then the oncologists on top of that giving a perspective on their view as to how the treatment might be managed based on those two. I think one thing I've seen visiting many MDTs is there is often a driver in that MDT that dominates. So it might be the pathologist, might be the radiologist, and they're absolutely convinced that they've got the right answer. And I find this very helpful in terms of the discussion, but not in the conclusion. So I think the conclusion has to be, there has to be an equipoise between those three dimensions, which is the treating oncologist, the pathologist, and the radiologist. So Tony, you must have come across many of these conflicts.
Yes, all the time. I don't like the term true cup. Cup is when you cannot find an anatomical primary site and the patient has metastatic disease. And if you do appropriate pathology and you believe that it's a lung cancer based on your immunohistochemical studies and clinical features, then you would obviously treat as a lung cancer. But the patient has cup subset lung cancer. They still have the cup syndrome, but they likely have an occult lung cancer. In the GI tract, you mentioned the problems. Their immunohistochemistry and even molecular testing, there's so much overlap because the mucosa, for instance, of the pancreas and the biliary tract and the gallbladder are all contiguous. The mucosa of the mullerian epithelium of the endometrium and the ovary are contiguous. So it's very difficult to differentiate those cancers once they metastasize. The use of molecular testing has really helped us, though, in differentiating various gastric cancers. I might add, in one of your interests, intrahepatic cholangiocarcinoma is much more common than people think, because many times they're called CUP. They're called metastatic adenocarcinoma of the liver. There's no good absolute marker that's used most of the time by pathologists. So they aren't sure, unless it has a typical histologic pattern. Intrahepatic cholangiocarcinoma is difficult to diagnose. And molecular testing can really help there. And if you think it is, there is a test you can do, an albumin in situ hybridization that's virtually always positive in intrahepatic cholangiocarcinoma. It's also positive in hepatocellular, but those two can usually be differentiated. So that's an example, just one example, where we can start to divide the upper GI malignancies from one another, even though the patient presents without a known anatomical primary site.
Thank you. Now, some of the other questions that have come across, I hope that as we were speaking, we've sort of touched upon them. And a couple of them will come in the next section in terms of where we're going, where the field is going. I just wanted to touch on a couple of questions that have come from the audience, and it's going to be a different answer from the US to the UK. And the question was how much of these tests cost. So this is to any of the RT-PCR test costs, and they've come down dramatically. And Tony, do you have an estimate of what they cost in the US?
Yeah, if a patient pays for them in cash, if the patient pays, it's between and it's negotiable. It's between $500 and $900 for the RT-PCR. Now, third parties, even Medicare in the United States, which is a government program for the elderly, they are charged more than that, but they won't pay what's been charged. I'm not going into medical economics and different countries. It's too complex. But the fact is, these tests are coming down. In general, I'm going to say the average is around $1,500 for that test. It's much less than a PET scan, which I rarely recommend in cut, by the way. Much less.
And that's interesting you say that, because the volumes that you use in the US have probably driven the cost down. When they first started here, they were in the sort of £1,500 to £2,000 range. But the volumes in the UK are not very high. So the companies have lower turnover. So their cost is probably now, where it was cheaper than the US, is now probably slightly more expensive. But it's not far off that ballpark that you've just described. An ancillary question to that, which I think overlaps with what we were talking about, was what if the tissue of origin test it differs from the pathologist's view? So one of the things I wanted to say is that despite the fact it's taken a long time and there was a hiatus with COVID, this is exactly the question that we're asking, and the analysis is actually undergoing in Glasgow right now, of a prospective blinded comparison between the expression of the tissue of origin test that was done by two third parties, so Biotheranostics and HealthScope, versus a centralized test versus your local hospital, which was the basis of Cut 1. So we will have a sort of a more metric answer to that with all its challenges. But Tony, what happens to you if you see the discrepancy? Do you then move to another diagnostic aspect to look at that and discriminate and choose?
Yes, there's not one answer, but I think you have to put everything together. You put the clinical features, all the pathology, and then the molecular test, the RT-PCR you mentioned, and you have to know the limitations of the RT-PCR test. It's not a perfect test. There are overlaps. It can't diagnose rare cancers. The patient may have a rare cancer. Let's give an example. If a patient has a retroperitoneal mass and biopsy and it's an adenocarcinoma, and immunohistochemistry that's done is not diagnostic, and you do the RT-PCR and it comes back as renal cell carcinoma, papillary subtype. Now, the pathologist didn't do every stain. There are hundreds of stains. You could then go back, ask your pathology to do relatively specific renal stains, such as RCC, such as PAX8, there are others. And we've shown that in many instances, the molecular test is substantiated by this post hoc stains during after you have that diagnosis, and it actually substantiates your diagnosis. And that is one of the ways that occult renal cancer spreads into the retroperitoneum, into bones, into the lung. And yet you don't see a primary in the kidney because it's too small to see. You find it at post if you did enough sections. So there's an example of how you can sometimes determine this discrepancy. The other one I mentioned, and there are many others, Harpreet, of cholangiocarcinoma, where you're not sure and the pathologist isn't sure whether it's spread to the liver from another source or whether it's actually coming out of the bile duct. You can do an albumin in situ hybridization. It's like a FISH test. It's not difficult. Many labs do it. And it's usually positive in cholangiocarcinoma. It's usually positive. So if it's positive, that gets rid of the discrepancy. There are many other examples, and it's individualized. We don't always come up with the right answer or an answer that makes this understandable. And that's the way medicine is sometimes. But in the majority of patients with CUP, we feel comfortable if we use all the available information with the tissue of origin.
That's really, really excellent, because it also talks about another point that's been raised in the questions and answers, which is basically the more practical aspects of this discussion, which is, and coming back to a point I made earlier about whether CUP should be under specialist umbrellas or general hospitals or community hospitals, as you call them. The question here is about time. So the time and access to specialist services. Let's just give the example you had as the in situ for the albumin. One of the concerns that's been raised here is that it takes a lot of time when these patients are already in a poor condition to come back and forth with your sort of non-specific CUP MDT, whereas your specialist CUP MDT, for a better word, for want of a better word. And so I think the point being made here is very important, is that actually from a patient perspective, the time that it takes a specialist MDT to come to a decision to start treatment and do these extra tests as they go, and they become dynamic, new tests being new research coming out every year, compared to sending it back and then they have to arrange the tests that they're not familiar with. So I think there is a point there that's very important about specialization of services, which we've tried to do in the UK, Tony.
Yeah, very good point. We are trying to approach this with reflexive test. In other words, when we do an RT-PCR and we think the patient has a metastatic lung cancer, that tissue is immediately, next generation sequencing is done immediately, not spot testing, because there's so many genetic alterations in lung cancer. You have to have a more general test. It's done then. So usually within 10 days after they have the tissue, we have an answer. We have the answer on the RT-PCR in 5 days. So yes, you're right about the patients. And if patients are markedly ill and debilitated, it's unlikely unless they have a very treatable type cancer, it's unlikely they're going to do well no matter what you do and no matter how much time. But if they're ambulatory and they're in reasonable overall functional status, you have 10 days. You usually have 2 weeks. Going beyond that is, in my opinion, not a good idea. And we rarely go beyond 2 weeks before we have an answer.
It's very impressive, the 2-week turnaround, because I think what we experience in the UK and many of the frustrations I think that the audience is sharing with is that we tend to do tests sequentially rather than on the spot, which is what you've said is the ideal model. And ironically, I had this discussion earlier on today with the head of the genome testing in the UK, that actually when different labs do different aspects, so for instance, we're split so that if you want to do PD-1 staining or you want to do MSI, you want to do HER2, they're not all one route, one-stop shops. They're all in different laboratory silos. And we end up doing them sequentially rather than on the spot as a sort of a block test that we don't have to fight about which bit of tissue we send to who. And that's one of the problems we've had even in CUP1, that 20 to 30% of the samples that we had with biopsies were not accessible by more than barely one technology. So the access to tissue is an issue here. I just wanted you to comment on that.
Well, I agree with you entirely. There are ways around this, but it takes a lot of organization, and reflexing the tissue is critical. Now, if you know the primary site, most of the big commercial companies like Foundation Medicine, they'll do those testing for you. You send the block, they'll do the PD-L1 stain, they'll do virtually all the important molecular alterations you need in any cancer, okay? It's just a CUP, you have an additional element. You need to know what the tissue of origin is first, in my opinion. You can't just do next generation sequencing on all the patients and ignore what the tissue of origin is. That's what's being done now a lot. And well, you know this, and then I don't think that's the best approach for CUP patients, but we could talk a long time on
Yes, agreed. So it takes us nicely to the sort of the last section of this before, and we're obviously encouraging more audience participation. But just before I move on to the last section of how you see the crystal ball in the future, I want to just ask you about, in terms of practice, what we find here in the UK particularly is that having patient support, palliative care, as well as nurse advocates, particularly for supporting the patients at the outset, because they're so poorly in the majority of cases, is a really important part of this whole treatment pathway. So we can get lost in this research and the technologies and the DNA and the RNA. But when we come down to the patient, this is a really important aspect. Is this something that you have already sort of set up in the US in terms of parallel management for these patients at a very early stage?
Yes, palliative medicine is involved in almost all of our patients. Sometimes they see the patient and they say, well, we don't really need to see them right now, but that's important too. So yes, that's extremely important. And we do that routinely with these patients.
Thank you. Can we now move to a bit of crystal ball gazing? We start moving from the tissue of origin tests in tissue. And one of the questions also is related to this that we were going to discuss, moving to blood testing. So what I want is some views from you on certain aspects. So if you could cover this as to how you think this is evolving in your practice and in the US generally. But before we move to that, we know that commercial companies that you alluded to earlier are much more nimble in incorporating new things. And one of the things that, for instance, the Foundation Medicine has incorporated in many of our clinical trials is their liquid CDX test. And in fact, they are reflex offering commercial testing for that first. And then if they don't get a result, to test the tissue for free. So it's not a double commercial charge, basically. So that's what I call pretty innovative for our patients, even though the cost is still in the many thousands and unaffordable for some of our patients. And the way that they work is so much more nimble than big organizations like the NHS, which we go through something called a test directory and regional testing. So we have to encourage certain tests to be put on the test directory for our patients for each cancer specialty, including CUP. And it ends up being a year before it gets incorporated. And by that stage, we now want more tests in a different dimension. So I think the commercial sector is still way ahead of us. But moving towards the commercial sector and new developments, I wanted to talk to you about your view on ctDNA. And in the UK, there's also a pilot for, as you've got in the US, for early diagnostics for our patients through the GRAIL test, for instance. Yeah. And I just wanted your general views on those two aspects as we move forward.
Yes, I think blood testing for circulating tumors, cell-free DNA is advancing rapidly. It's been compared to tissue testing in many instances, in particular subgroups of patients, is just as good, and probably is going to end up being better as it's refined, because cancers are mutating and you can actually do the test serially and see that and make therapeutic decisions. I think that's in the future. I'm a big fan of blood testing in this regard. I don't think we're totally there yet. For instance, in lung, you can't pick up all the molecular alterations that are highly treatable with targeted drugs yet with blood testing, but you can pick up several of them, but not all of them. But with, for instance, foundation tissue testing, you can pick up all these fusions and other important. Close to 35 to 40% of lung cancers have an important target. That's remarkable when you think about it. And the most recent one is basically the KRAS, the particular KRAS mutation, which is highly treatable with targeted drugs. So this is one example of this. So that is becoming very important, and I think is part of the near-term future in this disease. Other important issues are the genetic and epigenetic study of CUP patients, the cancer cells themselves. I think in the future that we're going to understand the mechanisms of the CUP syndrome. Why does the tumor remain, the primary remain so small? yet can metastasize, and the metastases grow, and we find them. And we're going to learn the underpinnings of not only CUP, but all cancers. This will take longer. And therefore, if that happens, it won't matter what the tissue of origin is. We may end up with superior therapies based on the genetic lesions and epigenetic lesions that we find in these cancers. We're not at that point yet by any means, but we could get there in the future by a deep dive into the mechanisms. And they're certainly genetic and epigenetic. There's no doubt about that.
So that's really helpful. I just wanted to point to the audience where, first of all, we've got 148 participants, that we are taking the questions through the chat box. So a message came up saying someone had questions, but they've got to put it in the chat box. I'm going to move it back to the chat box for the Q&A for a point that you raised, Tony, already, and you covered.
Harpreet, sorry, just to interrupt. We're using the Q&A box for questions.
Sorry,
You're looking at the Q&A.
My fault, the Q&A box, not the chat box, and then I'm getting the questions through the chat box. Sorry, yes, I appreciate that. Apologies for that error. So as we move to the final sort of 10 minutes, we do want more interaction. So Tony, some of the questions that have come through, I think you've covered, and you covered just now again, which is that as we move forward to molecular typing and understanding cell biology and at the level of DNA, RNA, methylation, epigenetics, it may become that we don't need the tissue of origin, but that's in the future. What we need currently, as there's a question that says, should we not just move to actionable, I'm going to paraphrase it to speed things up, actionable mutations, i.e. we just want to know the ones that can be targeted and treated. But in practice, actually, that's a minority of patients still.
Yes.
So we can find what we call actionable mutations, but actually pairing drugs to them, particularly if you're in the UK, trying to pair the drugs is a real challenge for these actionable targets. So we do need to think about that in the future, but at the moment, we're still on the model of combining the information of the tissue of origin, the MDT outputs, and if we have additional testing, such as tissue of origin, RT-PCR, and then if we have the NGS with that, all of that information arms us with a plan. Tony, would that be fair from your comments?
Yes, I think so. Actionable mutations aren't always actionable depending on the cancer type. For instance, BRAF V600 mutation in colorectal cancer treated with BRAF inhibitors is virtually without any benefit at all, single agent BRAF. Whereas if you treat a melanoma patient, the response rates are over 80%, and they do well for many, many months. So you see, you can't just say, well, they have an actionable mutation, we can just use that therapy. Now, there are some exceptions, but you mentioned, Harpreet, these are rare. NTRK fusions, high tumor mutation burden, microsatellite instability, which is high. Those are exceptions in CUP patients where you might be able to treat those patients initially with those drugs. However, you still could be making some mistakes. If you have a germ cell tumor that has a high microsatellite instability is high, treating that patient with immunotherapy initially would be an error. So you need, for all practical purposes, you need to know what the tissue of origin is before you treat the patient. If you can't determine the tissue of origin, either because you don't have the technology, then yes, you could go that route. And that's sort of, in some ways, the large study now that's going on, Harpreet, you might want to mention that. And I have a comment or two if we have time on that. But
sure. Yeah, I mean, I think that's an excellent point, because the word treatable mutations, actionable mutations has been really grayed out the reality of the situation, because it's so context specific, with your colorectal as an excellent example. And I think the study that we're all alluding to, which is probably in its final year or two, is the Capisco study, which is a global commercial study, where actionable mutations are being partnered by therapies, and there's also an immunotherapy option for the ones that we can't find a partner to specifically, so non-specific IO option. And that study is important for many reasons, even just the framework of how you set it up and the challenges, including the delivery, which has actually been relatively successful but challenging. And I think the information and knowledge we get from that will be excellent. So I don't think it's going to answer everything. And I think, Tony, now you might point out that there are flaws in it, but I actually think the fact that they took this on as a commercial project and a process is really, really important for our patients, just in what we've set up rather than maybe the outcomes. What's your view?
Well, I agree entirely what you said there, and I don't mean to put it in a negative light entirely, but the way the study was designed was to take all 30-some cancer types that are part of the CUP syndrome and give them all the same treatment to begin with. But the innovative part is all of them have to have NGS either with tissue or blood initially. And then the patients that respond to empiric therapy, and again, keep in mind, you got all sorts of cancer types in here. They're given a targeted therapy if they have a target. A lot of them don't have the targets that you have the targeted therapy for. And that's why you needed 800 patients on this phase 2 study, because otherwise you wouldn't have enough numbers to compare the randomization, which includes a 3-to-1 randomization, to give empiric therapy, or 3 times as many patients would get a targeted therapy, and then you're going to compare progression-free survivorship. So that part of it is interesting, and I think it will be a positive study because you're going to have some treatable, highly treatable patients in there who have targets like lung, whereas when you give them the empiric treatment, they'll be stable or respond some to like GEM and CIS, for instance, and then you'll give them a targeted therapy, and they'll do better than if they just would have received the chemotherapy alone, which is the other arm. I agree with that, but again, that if people take this study, if it's positive, and say, well, this is how we have to treat all the CUP patients, then we're missing the boat on what I said earlier about all these treatable subsets, lung, breast, melanoma, I go on. And they should be treated as if they have that cancer rather than all being treated with the same empiric therapy to begin with. You still use molecular testing in those patients as well. You just determine it initially and incorporate it into your precision therapy. So that's all. I think that should be the next best step, as we talked about earlier.
Thank you so much for that. That's excellent. We're sort of winding up. I don't want to be disrespectful to some of the questions, but I just wanted to say that some of the questions we have covered in the talk, but also if it's a personal question about an individual, I'm afraid we can't answer that, but you might be able to get support for that through the CUP Foundation, through John Simon's links as a personal development for yourself. And I do want you whoever that was, to be supported rather than be rejected on this conference. But the framework for this conference is really about generalities rather than specifics. So apologies for that. There's a very interesting question that I do want to cover, and then we can maybe do some closing remarks. If a tumor is picked up as a GI pathology, and everyone agrees that it could be a GI CUP, but you can't define where it is in the GI tract, should that be treated by a GI medical oncologist or clinical oncologist, or should it be treated by a CUP specialist, is the question. My view is it can be either, as long as you've got the framework and you trust the process of the individual. Yeah.
I entirely agree. I might add that the lower GI tract, usually we're going to be able to diagnose that with immunohistochemistry. It's the upper where the problems arise, and you well know this. Yeah.
If your oncologist has got experience with those specific drugs and can get access to those drugs, then that's absolutely fine, whichever domain they're in. Yeah.
Yeah, I would agree with that, of course.
Yeah. Okay, we're 4 on the dot. I can't see any further questions in the box. No, there is one more question. So this is a good one for you, Tony. So would the following patient be accepted onto Capisco? There's a met adenocarcinoma in the bone, TTF1 positive, but no obvious lung cancer. And so they're asking whether they would be accepted in Capisco. Certainly if they've started treatment, they wouldn't. If they've not started treatment, then there are criteria that may exclude them for other reasons. But Tony, that's a really good follow-on from your comment about a lot of these tumors are lung and it continue to be lung with specific options. So I think we both agree that that patient, whether within Capisco or out with Capisco, should get proper a DNA, NGS, etc., and fusion testing for the right treatment as well. Would you agree with that, Tony?
Absolutely, yes.
Yeah. But for referrals to Capisco, your closed center or us, we can screen them for you and turn them around and tell you whether they're eligible if we get the appropriate clinical information. So we're very happy to do that. And I'm pleased to say that in the UK, our patients still have access to 3 studies, at least. So there's the Capisco, there's the CUP-M, which is the second line Pembro study, which will is taking all comers as long as they've had one or at least failed at least one line of therapy, and that will close in December this year because we'll have hit our recruitment. And then, of course, we've got the 100K genome sequencing still in the background through the NHS England for the deeper sequencing, and there's a local program also going on in the Manchester region, which does a slightly more modern version of that. So there's lots of access to research in the UK that you can also get through John's Simon's website, Joe's Foundation. So I'm going to close there and thank Tony for an amazing hour. I always have a pleasure, and I missed you last time and had to do your talks for you when you couldn't get to London before lockdown. So I had to get your insights through the slides rather than directly from you, which is always a better experience. So thank you very much, and I'll pass it on for the closing remarks.
Harpreet, John, the audience, it's been great. Thanks so much.
Well, it's been a fascinating hour, and thank you very much indeed to our 2 experts. It's been a real privilege to be able to listen in to such expert conversation with expertly put questions too, which were tremendously helpful, I think, to the audience. And thank you to the audience for your questions, those who asked questions. Thank you to all those who've attended.
John, I just wanted to also thank you and CUP Foundation for sponsoring this webinar. I hope everyone who's attended has found it useful. It's certainly been a very interesting hour. Now, before you all go, I just want to tell you that you can view other upcoming and on-demand events on the SBK Healthcare website. And as Harpreet also referred to, is that on the CUP website, there's a lot of further educational material.